So I've been asked to talk about delayed awakening, and I will focus my talk on delayed awakening in sedated patient or deeply sedated patient. As we know, we all agree that we have to avoid sedation and to discontinue sedation as soon as possible. But patients, most severe critical ill patients or brain injured patients, often require sedation and deep sedation. For instance, patients with ARDS or patients with intracranial hypertension. Secondly, sedation is known as a risk factor for brain dysfunction, especially delirium and delayed awakening, and can mask for the occurrence of a brain dysfunction. So there are two issues: how to detect acute brain dysfunction in sedated critical ill patients, and how can we predict post-sedation altered mental status, including delayed awakening and delirium. So I will talk in this presentation about the definition of delayed awakening, the diagnostic approach in patients with delayed awakening, how can we predict delayed awakening in sedated or deeply sedated patients, and how can we predict neurological outcomes in non-awake patients after discontinuation of sedation. So there is no clear so the definition is clinical, of course, of absence of awakening, and it is characterized by the absence of spontaneous eyes opening. And you have to distinguish a persistent absence of spontaneous eyes opening from the fluctuating. The former is rather related to coma. It's a sign of coma. Fluctuating awakening is rather a sign of delirium, for instance. Of course, you can use scales for assessing the absence of awakening, for instance, Glasgow Coma Scale or the 4 score, or, of course, sedation scales as the RASS. And what is the delay for considering a patient having a delayed awakening? Arbitrarily, we're considering that it is more than 3 days after discontinuation of sedation, but this is completely arbitrary. So what is the diagnostic approach of a patient with delayed awakening? It is really comparable to assessment of any comatose patients. And I will repeat what I have already presented by Nino. This is what you have to do, the clinical examination that you have to do in a comatose patient. Of course, you have to assess the eyes response, the motor response, and the verbal response, but in intubated patient is not possible. And you can use different scales as the Glasgow Coma Scales, of course, or as the 4 score. And then you have always to look for focal signs and to see whether or not there is an asymmetry in the response between the left amoeba and the right amebodies. You have to look for the presence of myoclonus of the leads or the limbs. This is very important. And then you have to assess the brainstem reflexes that I will present very, very rapidly. So this is how you can assess the motor response. You all know that. And, of course, any focal signs require a brain imaging. And you have to look at the eyes positioned and also the eyes movement. I will go very quickly through these slides. And then also assess the pupils. Here are depicted the different changes in the pupil size according to the level of a brain dysfunction. And then don't forget this sign. This is a very important neurological sign, the Claude-Bernard-Horner signs. And it's very frequent in critical ill patients, and sometimes it can be related, of course, to a lesion of a venous jugular vein, by a central catheter. So you have to assess the different cranial nerves, and you know the semiology of the third nerve palsy. Nino Stocchetti have already presented the different signs of herniation, and so, of course, this is very important to know because this is you're in neurosurgical emergency situation. The 6th nerve palsy, I won't describe this, and also to assess the oculocephalogy response. The respiratory pattern not in patients who are intubated. Most of the time they are intubated, sedated, and synchronized with a ventilator. But you have to assess also the cough reflex in intubated patients. And then you have to, this is how the algorithm of decision on the complementary investigation that you will decide upon your clinical findings. You have also to take into account the medical history and the circumstances, and of course a fever with coma you have to do a brain imaging and then a CSF analysis, if it's possible. Next steps, you have to do a brain imaging and then a CSF analysis. Focal signs required in a brain imaging. And if you have any signs of seizure, do an EEG and then a brain imaging. And according to your suspicion, an EEG, a CSF analysis. And if you don't have any explanation for the coma, you will discuss about the usefulness of EEG, brain imaging, and CT scans. This is what you have to do in any comatose patient. In an acute, in a critical ill patient who will develop an acute brain dysfunction that can be focal neurological sign, myoclonus, coma, or delirium agitation, you have the same cards. So you will have to look at the biological standard test. You have to decide whether or not you will do an EEG if you have a suspicion of seizure, for instance. If you will do a brain imaging because you think that there is a brain lesion, especially if a patient has a focal neurological signs, and if you will do a CSF analysis because you think that there is a meningitis. And if we are now focused in a patient who present a delayed awakening, these are the different factors that can contribute to this delayed awakening. Of course, the sedation and how was the duration of sedation, the depth of sedation, how it was managed, you know, if it was titrated, if you followed daily discontinuation of sedation, and the agents that you have used, for instance, midazolam, more prone to favorize delayed awakening than propofol. We all know that. And maybe you will discuss the usefulness of antagonists to be sure that it is not due to the still presence within the blood of sedative agents. So take care of antagonists. You know, it can provoke seizures, so you have to take care when doing these tests. Of course, organ dysfunction will interfere with the metabolism of sedative agents and will contribute by itself to delayed awakening. The cause of admission, and this is very important. Of course, you need to know maybe the delayed awakening is related to the cause of admission in ICU and also to the pre-existing disease of the comorbidities. And so this is very important. If a patient is not awakening after discontinuation of sedation, you have to look at all the chart and understand what was his historical medical history. And then you have to seek for any intercurrent complication like drug toxicity, metabolic disturbances, dysglycemia, of course, hypoglycemia, and sepsis, etc. And then, as I told you, you have always the same cards. You can say that neurology is very simple. At the end, it's finished by MRI, EEG, and CSF. Yes, you can say that, but the order of doing this examination is also quite tricky. So a neurological examination is still important, and time too. So this is the different cause of delayed awakening that we can see in patients. I cannot give you any prevalence for each of these causes, but it is really comparable to etiologies of coma. So I would like to draw your attention to seizure in ICU. You know, seizure can, and especially non-convulsive status epilepticus, but any seizure can, be revealed by a coma or a delirium or an agitation, psychosis or lethargy. So if you have a patient with delayed awakening and you think that it's not due to the fact that there is a delay in the metabolism of sedative agents, and you think that there is something going on at the brain, it can be a seizure, and do an EEG. So, of course, the epidemiology of seizure in ICU is not so well known. Of course, when reading the literature, you will see that it depends on the population, the definition, and this is clinical definition or electroencephalographic definition, the monitoring that you have used, the continuous EEG or standard EEG, and of course the use or not of prophylaxis. You know that, for instance, in TBI patient, you use anti-epileptic drugs as prophylaxis. So this is the incidence of the prevalence of a seizure, convulsive seizure or non-convulsive seizure in ICU, and you can see that it ranges from 20% to 50% according to the type of population, to the severity of critical illness, and to the type of monitoring used. And in critical, so, and this is, you can see, can ranges up to 78%. And this is the etiology, so this is really comparable to the etiologies of coma or any acute brain dysfunction. And don't forget that we are using drugs that can be really pro-epileptogenic, like antibiotics, for instance. So, and this is a quite old study done by Vijik. They have looked at the different etiologies or causes of seizure in medical and surgical critical ill patients. And you can see that drug withdrawal is a major cause, metabolic abnormalities also, and drug toxicity. And once again, I say pay attention to antibiotics. They are really pro-epileptogenic sometimes. So just some causes of delayed awakening. We have looked at a cohort of patients with septic shock, and we have assessed the occurrence and the type of acute brain dysfunction in this patient. Most of these patients were sedated. And you can see we have analyzed about 71 patients who underwent MRI. And as you can see, focal neurological sign was observed in about less than 20% of patients, seizure in about less than 10%, and delirium and coma. Coma was delayed awakening, in fact, more than 3 days after discontinuation of sedation in about 50% of these patients, very severe septic shock patients. And we have done an MRI in this patient. It was the purpose of the study. And as you can see, the MRI was normal in half of these patients. But in the other half, you could see either ischemia or leukoencephalopathy, white matter hyperdensities. This is so what is interesting is that you have the likelihood to have an abnormal MRI depends, in fact, in comatose and patient with coma and delirium, depends on the intensity of EEG impairment or abnormalities. So in patients who develop delirium and delayed awakening, if the EEG was abnormal, you have more chance to have an abnormal MRI. Of course, MRI was always abnormal in patients with focal neurological sign and seizure. And this is the type of damage that we have seen, ischemic stroke in these patients. And this is the case of a patient who was referred to our ICU for an ARDS. She was immunocompromised, and she developed a very severe septic shock with intravascular disseminated coagulopathy. And then we stopped the sedation, and she did not awake. And we decided to do an MRI which showed this stroke, and you can see the obstruction of the occlusion of the middle cerebral artery. This is the other type of lesion that you can see in this patient, and sometimes diffuse white matter hyperdensity. The last case was a patient with COPD who suddenly developed at time of extubation a septic shock related to septicemia with pneumonia, with Pseudomonas, and she developed a divergent gas with coma, and we saw this lesion. So this is also an interesting case. I was on call on Sunday. It was a long time ago because now I try to spare my weekend. But my colleagues say, okay, you will have a very pleasant day, nothing to do, and especially this patient now, she's sleeping, she's very well. And so this patient was referred to our ICU for a very severe RDS, and then we stopped the sedation, and she was in this state. Do you think that she's sleeping or not? You know, when you're sleeping, usually you have your eyes, upward. No, she was not sleeping. She was in coma. So, delayed awakening is not sleep. Delayed awakening is sometimes coma. And this patient, in fact, has a cerebral, an ischemic stroke related to an aspergillus vasculitis. And of course, unfortunately, she died. This is also an interesting case. This patient was referred to our ICU for a pneumonia with pneumococcus, streptococcus pneumococcus, and he developed an ARDS. He was heavily sedated, deeply sedated, and then he was led for a few days, deeply sedated, and then the sedation was discontinued. And one of our senior came and examined the patient and say, oh, there is something wrong. He has a bilateral enlarged pupils. And in fact, this patient was brain dead. And we decided to do something. So we did a CT scan, brain edema, and we say, oh, maybe we have to do things, les carottes sont cuites, as we used to say, but I don't know how to say it in English, but so we decided to do a CSF analysis which showed meningitis. So this patient died from a meningitis. And so this is very bad because there was not at any time any neurological examination. The patient was, when the patient developed agitation at the beginning of his admission, people say, this is alcohol withdrawal. They didn't think that it could be a meningitis. So take care. Delayed awakening sometimes in patient can be related to serious condition. And this is another patient referred to our ICU for a very severe RDS. He was treated with protein C, and he developed. We stopped the sedation, and we didn't awake. And we did a neurological examination which showed brisk reflex, tendon reflexes. And then we did an MRI, and this patient has a subneurocutaneous hemorrhage, and he didn't recover, and he died. So sometimes delayed awakening, most of the time, is related to, a delayed in metabolism of sedative agents, but sometimes it can be due to serious condition. So can we predict a delayed awakening in deeply sedated patients? So we have tried to answer to this question, and this is a study that I've presented several times. In deeply sedated patients, we have done the same neurological examination that I have already described to you, and every day until discontinuation of sedation, and then we have looked at the occurrence of delirium and mortality, etc. And so what we have found that there are patients in whom, we have found that there are some brainstem reflexes which are very often abolished, like, the oculocephalogeal response, and we have found that some other brainstem reflexes were relatively spared, so preserved, like the corneal reflex or the pupillar light reflex or the cough reflex. This doesn't mean that sedation cannot abolish these reflexes. Of course, yes, but in most patients with the dose that we are commonly used, some reflexes are really resistant to sedative agents, some other are really often abolished by sedative agents. And we have found very briefly that absence of cough reflex was associated with mortality, but most interestingly, we have found that the absence of oculocephalic response was associated with delayed awakening or occurrence of delirium after discontinuation of sedation. So because I'm a little bit neurologist, so I'm interested also in syndromes, like any physician, of course, but not only one by sign, and to see if there are particular combination of sign, and if particular combination of sign is associated with a particular outcomes. So this is a study that we have done, and I think, Romain, you have participated to this study, and we have done it with Benjamin Rowe, who is working at la Pitié-Salpêtrière with Sophie Demeret. We have studied 141 deeply sedated patients with RAS -3 by midazolam and supratenil. This is the duration of the midazolam was about, administration was about 4 days, and time to awakening was about 1 day after discontinuation of sedation. And this is the evolution of the progress to awakening in patients. So we'll go very quickly through this. We have used a particular method, which is the latent classes, which enables to assess what are the profiles, the combination of these different brainstem reflexes. So we have entered into the model the eyes response, the motor response, the miosis, the pupillar light reflex, the corneal reflex, the oculocephalogeal reflex, the grimace, and the cough reflex. And we have found that there are two profiles. One rather characterized by reactivity and the presence of reflexes, but somewhere can be abolished, like in 1/3 of patients, like the oculocephalogeal response. And the other profile is characterized by the absence of reactivity and a decrease in most of brainstem reflexes, but especially the grimace, which is completely abolished, and the oculocephalogeal response, and in less extent, the cough reflex. So this is another way to present these two syndromes, and you can see they are very different, and one is more homogeneous and the other is rather heterogeneous. And what we found is that the profile B was associated with bad outcomes, independently of the severity of critical illness. And we have found also that the delayed awakening was more frequent in patients of profile B, delirium was more frequent also, and 28-day mortality was also more frequent. And we have, so this is the multivariate analysis. For mortality, we have not done it for delayed awakening. We have developed a score, which is the BRAS score, and it's not already published, so this is, you have to, don't take caution to these results, but this is a score that we have developed in order to assess brainstem dysfunction in deeply sedated patients. Maybe it would be interesting to develop such a score for predicting delayed awakening. It was a score for predicting only mortality. So we think that we will have some arguments for a brainstem dysfunction in our deeply sedated critical ill patients. I won't describe quickly this. I will describe these slides. So do we have some other tools that can help us to identify patients at high risk to develop delayed awakening? Yes, maybe EEG can be useful. And the absence reactivity, we have found that in septic patients is associated maybe with delayed awakening and occurrence of delirium. And evoke potential, this is a study that we have, a pilot study that we have finished and that we will we have submitted. We have done evoke potential in sedated patients. For brain injury or non-brain injury, we have done somatosensory evoke potential and brainstem evoke potential. And to go very quickly through this, we have found that the interlatency, this interlatency, if I can, this one, between the P40 and the N20 was increased in about a third of patients and was associated with increased mortality. And we have also found that the interlatency between the third wave and the fifth wave of the auditory evoke potential was associated with delayed awakening in these brain-injured or non-brain-injured, deeply sedated patients. So this needs to be confirmed. So if you have now a delayed patient with a delayed awakening, he's not awakening despite the discontinuation of sedation, is there a way to predict his neurological outcome? I don't know. Maybe we can be inspired by what has been done in patients with post-cardiac arrest comatose patients. But this is another story, and I have to stop here to invite you to the NICE, the next Neuroscience Intensive Care International Symposium. We will talk about neuroinflammation, but also acute brain dysfunction in critical ill patients. Et je vous dis merci en français. Thank you.